Okay, welcome everybody to this third Europe Vision session. We will have two speakers in the session today. The first speaker is Natalia Zylinksa-Puta, who is involved in digital healthcare already from 2010, as well on a national as an international level. If you have any questions, please use the chat, and after 20 minutes we will open the floor also for you to ask anything you would like to Natalia. So Natalia, please go ahead with your presentation.
Thank you very much, Esther, and thank you very much for the invitation to this event, and welcome all the participants. I'm happy you are here with me today. And I would like to present you our work in the Commission on MyHealth EU project, which is actually enabling the patient's health data cross-border exchange, and also the future of those services and the next steps which we are taking now in regards of the European health data space. So just to start, we have two core services in our systems. We are enabling the exchange of e-prescription between countries. So when, for example, I'm traveling for summer vacations to another country, like to Spain, and I have my reoccurring prescription, for example, prescribed in the Belgium system, then when I will not dispense it in Belgium, I can go to any pharmacy in Portugal, and then based on my ID card, they will find this e-prescription and they will dispense me the medication. So I do not need to worry that I do not have my physical prescription with me. The other service is the patient summary one. So we are enabling the exchange of the patient summaries between hospitals and between healthcare professionals. And this is usually now used in the emergency mode. So when we are traveling abroad, we can have an access to our data, crucial data like emergency data, such as allergies, current medications, previous illness, or surgeries. This case so far was used mostly in the emergency mode, so I need to be honest that we have much more e-prescription exchange than patient summaries. I expect it's because patient summaries, e-prescription is something what we always want to have an access, but patient summary in the situation is it's in the situation which no one of us wants to face ourselves. So when we travel somewhere, we never think that something may happen to us, although the service is available and it's good to be aware, and we count here on the member states promotion of the service so patients start using it. So what are the two main benefits of the MyHealth EU system? It empowers the citizens by giving the secure access to their health data abroad, but also it strengthens the cooperation and synergies between member states themselves and member states and the European Commission. And on the next slide, which will show a bit how does the infrastructure of the system looks like, I will show you what are the necessary elements to be part of the system and how the synergies are being strengthened. So far we have 7 member states in routine operations. Those are member states which are exchanging the data. And I will start from the example of Finland. So each of the member states to exchange the data cross-border needs to set up so-called national contact point for e-health node. This is the open source system which was developed by the member states and now is sustained by the Commission. And based on the system, this is some kind of European connector. So each of the country need to install the system at their side. There are 2 main components. It's the national contact point, so-called A site, for exchanging the data of the country's own citizens. It means if Finland would like to have this component, first of all, they need to have a data of their patients in their country in the electronic way. And then as part of the implementation, they need to connect the NCPA to their national infrastructure and the clinical documents repository to enable the flow of the data. Then, of course, they are very specific standard agreed by all the member states and data set in which the data are being exchanged. So the data between before they are flowing in the cross-border level, they need to be first retrieved from the national infrastructure. They need to be coded, then mapped to the other dictionaries, and then translated and to the language to the doctor to whom they will travel, and only then they can leave the country and they can be displayed by the healthcare professional in the other country. But also the other feature is that the country actually can help the foreign citizens requesting the help in their country. It means that at that time, the country itself needs to enable healthcare professionals or the pharmacist to use the NCPB. So they need actually the interface and the portal which is being connected to the NCP to display the data which are coming from the NCPA from the other country. So here they have a direct contact with the patient, and they do not store those data. They are framed from the different country. And this is all what each country needs to do on their own level. As that you can see, it looks quite similar. The requirements are very similar, but then the infrastructure in different member states look very different, you know. So the challenge in connecting the national healthcare systems to the national contact point for e-health is always a different type of task for each of the member states. But even here you can see that now each of the countries has their system in place, but there is no flow of data, you know, there is no connection between them. So still we cannot talk about the exchanges of data. And here is when the Commission comes, and this is our role in DG Santa as providing the Commission core services. We are providing the secure connection between all member states through TestNG. We are enabling the NCP's localization and configuration through the e-delivery components such as SMP, SML. We are providing the central terminology services. It means that we are storing the master value catalog, so the catalog of all the data sets by which the data which are being sent to other member states are translated from one language to English and then through English to the language of requester, so the data can be understood by the healthcare professional in other countries. And then of course we are supporting all member states with the central service desk. And only with those in place, we can start talking about the cross-border exchange of data between NCPAs and NCPBs. And this is what is happening now. We are seeing the data flow. We have already more than 20,000 e-prescription dispensed from the early 2019, and around 500 patient summaries being exchanged. So this is how the MyHealth at EU works. This is the service provided by the European Commission, and we are working here with the member states governments. It means that when member states decide to implement MyHealth at EU, it's the decision of the government. To go live, country needs to go into the very thorough scrutiny process, and one of the criteria is that actually in the national legislation of the country there needs to be a provision saying that now when the data of the patients from this country will be exchanged with other member states, they have to be exchanged through this infrastructure. So we call it a project because for us, you know, for every member state it is a new cycle of implementing the task, and I will show you more details in a second. But once it is implemented in the member states, it is there to stay. I cannot say forever, but it's there to stay because it's a part of national legislation, and there will be only more use cases to add it. And now also the MyHealth at EU is the part of the European health data space for the primary use of data. So this will be the pillar of the European health data space. So far, as I said, we have 25 member states who joined our project. 7 are already in operations. This is Estonia, Finland, Portugal, Croatia, Malta, Czech Republic, and Luxembourg. And then in 2021, we will have quite a lot of member states joining. It's 9 member states. The reason is kind of the big accumulation, you know, because most of them were supposed to join in 2020, but due to the pandemic, this could not have happened, mostly because our teams I'm talking about our team in the Commission, and also those teams in the member states were also involved in implementing the European Federation gateways for interoperability of the corona tracing apps and the digital COVID-19 certificates. So quite often the teams were shifted to other tasks, and only now we are back and we are facilitating their going live. And as you can see, there are more and more neighboring countries, so we are expecting more and more exchanges. And this is happening also based on the results of the other past projects, such as EPSOS and Expand. This year, we have added the new use case to our system. This is the exchange of original clinical documents, which member states will start using from 2022 because it was just adopted in our specifications, and now member states have 1 year to test it and to be ready with the service. And this will enable to exchange the data which are not translated yet, but they will still complement the patient summary. And then in 2024, we aim to start exchanging structured laboratory reports, medical images and reports, and also hospital discharge letters. And this is according to the recommendation on an electronic health record exchange format. And here we are cooperating with DG Sante and across eHealth project, who will help us to develop specifications for those cases. But what is common here, which you can see, is that it's not the patient who has an access to its own data in the way the infrastructure is built so far. Those are the healthcare professionals who, by our request, can access our data in the other countries. But as I mentioned also in our unit and with our member states on the high level from each member states, we have seen, especially during the pandemic, how important it is to this swift from the portals and applications to the mobile applications, and how important it is to give the patients direct access to the data. And for that reasons, we are now investigation by patients direct access to their translated data through MyHealth EU services. And of course, we are taking into consideration also the digital COVID certificate, which we have built in this unit. So we would try to integrate it. So in the future, all of our data can flow in the European app. I was talking a lot about our cooperation with member states. So indeed, we cooperate as the Commission with eHealth Network. eHealth Network is composed of high-level member states experts who make strategic decisions in digital health domain. And eHealth Network was set up by the Article 14 of Cross-Border Directive. So they are there to kind of decide on the strategic approach for the member states' digital health. And then the eHealth DSI is being implemented, and the decisions are being taken by the group of project managers from each country, the people who are managing the implementation of national contact points, and they are meeting in the eHealth DSI member states expert group. And additionally, Commission and the MSEC chairs are meeting to supervise operations in the eHealth Operational Management Board. This is our governance. I also wanted to show you a bit how it all happens and how complex it is to actually build the exchange of the secure exchange of the cross-border data, which is being, when you have requirement that actually it's a member states government, saying that this is secure infrastructure, because I think it's a much different task when we are talking about the exchanges of 2 or 3 hospitals or some entities, and when we are having, like in this case, the whole countries, whole ministries of health and prime ministers confirming in their legal acts that this is how the data of their citizens will be exchanged, and that they are taking responsibility for this process. And for that reasons, we have built quite complex process to scrutinize each of the member states joining, and member states are verifying the other peers, and they are taking decisions if they feel that them joining the exchanges of data do not pose any significant risk to their cooperation. So I will give you the example of the member states who have started as the first one to implement the service, and they were the quickest one to deploy it and to went live. So we have that the system, the initial implementation was financed through the Connecting Europe Facility Telecom program. In 2015, we have 16 member states who got the financing, and in first quarter 2016, they got the results and started the projects officially in January 2017. So for the member states who were the quickest, they had their preparatory test event in October 2017. This is one of the events which we host for member states. It takes 5 weeks to test all the services, and member states are preparing this testing. They are having this preparatory event in October, and then usually in January or February they are starting the final test event, after which they have to clear all the findings, and only then they can apply to go live. So the first member states had the official test event in January 2019. And when the infrastructure was tested from the technical point of view, then they needed to undergo the audits. The audits were, it was decided by the member states that each of the country has to be audited to make sure that the organization which is providing the service is secure and that the other countries can trust them. So audits usually takes from half a year to 1 year for the member states to clear all the findings. And then in October, member states request to obtain the decisions to go live, and it takes around 1 or 2 months for member states to decide if other member states can start exchanges. And this is how we got to the point that in January 2019, first member states went live. Then the testing events are happening according to the test framework, which was adopted by member states, audits according to the audit framework, and the decisions are taken according to the policy decisions also adopted by the member states. And then before member states go live, they also have to test their services in production environment. And all of those steps, we as a commission, we are supporting to each of the member states separately and to all of them together when they need our support when they are testing as a peers. And of course, meantime, we had other member states were in the odd steps. So when we were supporting some of them with audit and policy decisions, the other we were supporting with their implementation and the test event. So this is how it's ongoing for already quite some time, and we have more and more member states coming and supporting them. This is a short summary. I wanted to show you what type of data are already in the patient summary, which member states are exchanging. This is data about the patient and clinical sessions, about the patient's typical family name, given name, date of birth, but there are already quite a lot of clinical sections which member states they can exchange. It's such as allergies, relevant diagnostic test, problem list, history of medication, history of medical devices, and see how many coded and structured data are so far being exchanged and able for being exchanged to member states. Also, we have a data set, a normalized data set about the immunization. There is a name of vaccination, brand name, vaccination date, and when it was administered, and if it was administered. And for that reason, we are planning to add more and more data about the vaccination, not only COVID one, and have it in the mobile app. And on top of this, I told you that from the next years, member states will have a possibility to exchange original clinical documents. So we are planning to add the possibility to exchange medical images, lab results, and hospital discharge letter. And this is in the native language of the citizen. So we thought that this service is very important because look how many people are there from your countries living in the other member states, like 20% of Romanian, 16% of Croatians. But in terms of real numbers, I would like to also show you what is happening in Spain, our favorite country, which we all love to go. It's 1% of Spanish people living abroad. But look what does it mean in terms of real numbers. In January 2019, there were more than 9,100 Spaniards resided in other member states, not in the world, but in other member states. And here in the red, you have member states who are already able to exchange the data or which will be able to exchange patient summaries still this year. So out of those Spaniards, more than 250 of them, 250,000 were living in France. more than 28,000 were living in Netherlands and more than 13,000 were living in Portugal. It means those are the people who on a daily basis could use the services and could have their data transferred from Spain to the country where they are living. And in many cases, they also have a multilingual speaking doctor, or they are in some of the diasporas, they are also being treated by the doctors who are having the same mother tongue as they have. And we could really enable the flow of the data. Additionally, I wanted to show you how many IHE European health insurance cards were in circulation in 2019. Those were 250 million. So that many people in Europe actually, before traveling, requested the IHE to be sure that if something happened to them, they will be able to receive their reimbursement. So they were proactively thinking about being secure on their vacations. And for all of those people, we are also planning to implement, as I said before, this exchange of structured lab results, images, and hospital discharge letters, and this will be available for member states to implement as from 2024. This was our services in the nutshell. I hope you find it interesting. I don't know if you would have some questions to me.
Yeah, first of all, thanks so much for sharing this really interesting topic. I didn't see any questions in the chat, but that doesn't mean people won't have questions, I'm sure. So is there anyone who would like to pose a question to Natalia?
I got one. Max Hofer, Switzerland. Hi.
Hello.
Go ahead.
If the government has not subscribed for whatever reason, is it totally excluded that an interesting large hospital group would connect to that system?
Yes, it is totally excluded. As I said, it's a very complex cooperation between member states, and this is the cooperation between the governments. And especially it's quite complex when it comes to Switzerland. You know, we had a cooperation with Switzerland, but as these exchanges are based on the cross-border directive, each of the member states, it's only available for the member states or the countries who have transposed the cross-border directive in their country, and unfortunately it's not the case of Switzerland, although we had a cooperation with hospitals in Geneva and they were ready to implement the system. And as far as I know, because we lately have a discussion with them, they are building their national cooperation also using, as an example, using the model of the NCPs. So it's a pity, but indeed there is no agreement on the government level for the Switzerland to join.
Okay, second question. What's your time plan and status on the mobile connection for patients?
Mm-hmm. This year we will be launching the pilot implementation from the EU for Health program. We will be asking some of the member states, or asking member states to apply for the funds to pilot this solution. The idea is that we will not build any central solution. At least that's so far the idea, but we will allow give member states the funds to actually customize their national apps, because in many member states, patients already have an access to their data or in the app or in the portal. So it's actually pointless to find another solution to do so. But member states in our stakeholders, they will try to customize those portals, and within probably 1 or 2 years, they will have a lessons learned and some of the primary implementation. And then we plan to decide with the member states at the government level what features should be implemented and start enrolling the solution. So I think 2 to 3 years it's feasible. In some of the member states maybe quicker. If they will pilot, they can make the services already available quicker.
Thank you.
Thank you. Another question?
Even Sanders, IHE Netherlands. I'm a radiologist, so I'm interested in image and report exchange. It's part of the e-health, but is there already some experience between one of the countries that are already exchanging information?
No, because this
Okay.
is a very new use case. So indeed, now we have implemented this feature already in the system, but the first member states will start using it the earliest next year.
Okay.
So I think the only experience which we have as proof is the one which Cross eHealth is gathering, because this also has been done with the cooperation with them.
Yeah, and if I may follow up on that, this takes a bit more time because also if the information will be exchanged, for instance, images, it's good to have agreements on how to call them, how to categorize them, how to send them, etc. So that is a lot of work. Of course, you can send something via mail, but this is a bit more ambitious in that sense, to have really interoperable exchange of any kind of document, so to speak. Thank you.
And there is no exchange of images between Austria and Swiss. Austria is not in the call now. No, okay.
No.
I think they use. I think they use XDS for mainly for discharge summaries, but I'm not sure. And there is, of course, some exchange between the Netherlands and Germany in the Grensstreken project, where we exchange information, but not through MyHealth Europe. No.
Okay, I think we have 2 more minutes left for the last question, if somebody would like to raise it.
It's nice to see what the EU is doing. So, thank you.
Thank you very much for the opportunity to present. And in case of any questions,
yeah, I will find you.
Please reach out. Perfect. Thank you very much then, and over to you, Esther.